Thank you. Thank you, Barbara, so much. And thanks to all of our panelists. And we've certainly heard some recurrent themes here and themes that relate to some of the previous comments made in the session before this in terms of everything from public awareness to user acceptance to the human factors that may be involved in the way people make decisions. I'm going back to comments Jim Johnson made earlier in terms of just understanding the hazard, understanding and educating people what their options are, and really thinking about how people internalize perception of risk and how that may impact the willingness to use respiratory protective devices and whether or not they're going to basically exert the effort needed to understand how to use it properly and consistently. And so I guess my first question will go back to Rachel, because you really touched on the need for this social and behavioral research to better understand the context with when will people wear these devices. And also what I thought was very interesting was the intersection of your comment about how do we make these programs more acceptable and easier to implement in smaller employers and smaller businesses, which then sort of intersected with Ayse's comments about that organizational ergonomics. So if you both could address that, I think that would be really helpful.
Sure. I mean, I think what I was talking about is highly approachable through the human factors research methods that Ayse was talking about, that we want to think about it as understanding the needs of the users so that we can do a user-centered design, not only the design of the technology, but the design of the communications, whether that's through labeling, public-facing advertising, or going through the workplace where we could use workplaces as a way to reach more people. If they're educated in their workplace, it will influence how they engage in their personal lives as well. And so I think that it's a combination of needing to understand the user, whether you think about it from an occupational health, a human factors, or an advertising marketing perspective. What we're all trying to understand is, why do people do what they do? Why are they successful in why are some people successful? Why are some people not successful? Why are some people doing something that we can't understand, right? And how do we bring all of those perspectives together to tailor our messaging and tailor our technologies and our programs?
Thank you so much. Ayse.
Yeah, so I also really like Rachel's comments on the small organizations and their needs, because all the research I have done, not only in this context, but also for patient safety, an organization isn't equal to another organization. We are not in academic centers all. We have community centers in terms of healthcare, and the way their workflow is, the way their resources are so different. Hence, the importance of being able to tailor some of these implementation approaches. And that is what the implementation science. So if you want to implement one intervention program in an academic center versus a community or a rural setting, you need to pay attention to how you need to tailor that program. And the second comment I would like to make is I have done some work in the environmental care associates cleaning in the Hopkins, how they do patient room cleaning. And one of the big factors there that was in which you can think of it, it is not exactly the non-traditional worker in what we are talking today, but it is not a nurse, it is not a physician. These environmental service associates, one of the problems with them, with what they were saying in terms of why there aren't, the patient room cleaning is not being done as well as we wanted, is culture. And they didn't say it directly, but it's the culture and the relations and safety climate between them and nurses. They didn't think they are part of the team, for example. They thought they are behaved differently. So these things may definitely, this larger system may definitely impact, the safety climate may definitely impact how much you will follow some of the guidelines that are given to you by your respiratory protection program.
Great, thank you. Another question, Barbara, you made some just really important comments in terms of challenges that we've had with educating the public on respiratory protective devices and who understands what a respirator is, and the use of the mask as this blanket umbrella term, and even extending it to this issue of do the people that the public would go to for information to understand what type of respirator should I be using in my source of employment or for the COVID response, that perhaps the physicians and some officials aren't really understanding this either. And so when I kind of frost that with a cake of misinformation and myths that we have been dealing with throughout 2020 as it relates to protective devices, have we made any progress at all with getting the public to understand what is a respirator and how do we begin to educate those key stakeholders to be able to advise the public?
Well, I think we have made some progress. And again, I'll speak to the wildfire smoke example. Because wildfire smoke is a hazard that is in so many different parts of the country now, and more people have experienced bad smoke events. And this is an example of a hazard where you can see it and smell it. So that's a little different than COVID. So maybe it's a little bit easier. But I think people through the media and coverage of these events, they've become familiar with things like the air quality index to help them assess the degree of hazard that they're facing. They can smell it. They know it isn't healthy to get it into their lungs. And I think people are more motivated now to protect themselves, or at least a certain proportion of the public is. I think we've begun to promote having respirators on hand as part of emergency preparedness, related to these hazards. So that when the COVID pandemic started, at least around where I live, many people had filtering face piece respirators in their emergency kits, and have started using them on their visits to the grocery store even before we really rolled out face coverings, and especially among older people who got the message that they're at higher risk for COVID and they needed, to protect themselves. So, I think it's a slow and steady progress, but we clearly have a lot more to do.
Thank you. One question came in from our participants. If physicians know little about respirators in general, what standards are they using to clear typical users or workers in respiratory protection programs? And are they instructed on what follow-up testing would assure safe use?
I'm not a medical doctor, so I'm not going to speak for all doctors out there, but I think there's a distinction between the occupational medicine physicians and nurse practitioners who do respirator medical clearance. I think they are more informed on what to look for. And if they feel, if they're, they do the initial screening questionnaire and people say yes to certain things like, having asthma, they know what to do. It might be pulmonary function testing to assess the degree of impairment or something like that. I think it's the primary care providers who, when we tell the public, oh, don't put on a respirator till you've asked your doctor, and they go ask their doctor, I don't think they really have a clue what to say. But again, I'm not a medical provider. This is just more, of what I've encountered and what makes some public officials who are physicians, kind of go down that path that a filtering face piece respirator, which doesn't provide a lot of breathing resistance. And if people experience problems, they can immediately take it off and leave the area, pursue other options. These are the things that come up when we try to make those recommendations, and people are like, oh, no, maybe there's problems with respirators and we'll have liability or something related to it.
Yeah, thank you. Thank you very much. My next question, Ayse, this goes back to something you mentioned in your presentation, which just really resonated, and that's this idea of not only the need for robust interdisciplinary science on respiratory protective devices, but work imagined versus the actual work done. And I hearken back to some of the presentations yesterday and think about those workers in agricultural fields, in landscaping, who are exposed to air pollution and all, wildfire smoke and things like that. How can human factors engineering enhance successful respiratory protective device performance and programs for those non-traditional workers?
Thank you for the excellent question. So there are multiple ways we can help work as done versus work as imagined. I will, when you look at the protocols, what we think we are communicating with some of those guidelines or protocols or training materials, and how they are perceived and how they are in the actual work setting is not possible or very hard to do. There is this big gap. We need to understand these gaps, and this requires, it is not only, I think, perfecting the tool or technology, it is also understanding its use in the actual care, actual settings, whether it is the wildfire setting or agricultural meat packing. What are the challenges in that environment, and what are the strategies that people have developed, and trying to learn from all these. So it requires, as human factors engineers, we have expertise in identifying these using in-depth ethnographic studies or qualitative and quantitative studies to identify these gaps, and then bringing everyone, all the stakeholders, using a participatory ergonomics approach to the table to develop some, both can be very innovative solutions or can be some simple solutions, but that are not perhaps a person figured out doing something in a better way, but not everybody figured it out yet. So how can we translate that expertise around the community or public or the worker groups at a faster pace? So it's more like accelerated expertise development. So these are some of the ways. And I want to also mention the training aspect. The training needs to be developed to supplement the design flaws, right? If there are any problems with, if you have a technology that is so easy to use, you won't need any instructions. You won't need any training. So instructions, labeling, and training are for not flaws, but I should say the limitations of design to some extent. And some of it we cannot do. It's so hard to do it. So we need to develop the training, not just like another PowerPoint. We need to develop the training based on what are the risk points. We need to identify risks for why people are perceiving things differently. So we need to do a systematic analysis of why people are misunderstanding what we are trying to tell them, or what are we not telling them in a right way. And then training needs to address those. So we need that systematic engineering approach in the training development as well.
Great.
Thank you.
Thank you so much. We have another question that's come in from our audience participants, and it's just following up to this comment I believe that I made earlier about misinformation going around. How can we effectively address people's unfounded fear around oxygen deficiency behind mask and barrier facial coverings?
That's a good one. I'll take a stab.
I don't think anyone wants to answer it.
Challenge for sure.
I'll take a stab at it. I would say you need a trusted spokesperson like Dr. Fauci to get out there in mass media to address it. Obviously you need the basic facts. But I think that these misconceptions or rumors that are floating through and used as excuses not to pursue these control measures just need to be addressed head on in FAQs that are posted but the best thing is to have a trusted spokesperson with the facts, address it in a very clear way of communicating.
Tanir, this is John Balmes. May I chime in as a physician?
Yes, please do.
So first of all, I totally agree with Barbara about the messaging. I don't know if we can get Dr. Fauci to do it, but this is where we need a national strategy about respiratory protection, especially in the context of COVID-19, the pandemic. And as we discussed yesterday, to some extent, Stephanie Holm in particular, the physiologic impacts of wearing almost any kind of respiratory protection are not very severe. Cloth masks that aren't properly designed so that there's a lot of airflow resistance are probably worse than any N95 or surgical mask. So Barbara's right. There's very little evidence to support negative physiological consequences of wearing these masks. And it's not just primary care physicians, though I agree with her about that. It's county public health officers in California in particular, who've been railing against the harm that will come to people with pre-existing asthma about wearing N95s, which they're the very people that should wear N95s when they're going out, if they have to go out during a wildfire air quality episode. So how we develop that kind of clear and simple messaging is another story, but we need to do it.
Thank you, John. Those were really, really valuable comments. Well,
I'm just going to say too, I think that the misperception, it's not just in the general public. I mean, this has come up in like reopening education that I've been involved with, with manufacturers in Utah, that they're coming back with questions. And these are groups of people who wear respirators with some regularity, and they still have questions or concerns that come up that, have been circulating in the context of COVID, but must represent an underlying gap in knowledge about how the devices work. So I think that we now see it more prominently, but I think it represents a gap that was already there.
Yes, absolutely. I couldn't agree with you more. As we're reached the time to wrap up this session, I want to just open it up to our panelists for any final remarks or comments.
I'll just say one last thing, and that's I really appreciate NIOSH and PPTL's use of meetings like this to really get together an amazing spectrum of people to talk about issues and, to use all of that information to inform where they're going with addressing some of these areas. So I'm sorry I couldn't participate yesterday, but I have today, and thank you for organizing such a great meeting.
I would say one thing too is that I think NIOSH is considered a trusted source, yes. And I think that NIOSH should leverage that to do more research with the general public and more public communication. There's a lot of fear for OSHA. So I think but NIOSH is a trusted source and has the expertise. So I would hope that one of the outcomes is that NIOSH moves more aggressively into this space.
But NIOSH would need more funding to do so.
Yes.
Fair.
And they should get it.
Yes, I agree. I think there should be more funding and and more funding on not both to improve the devices or respiratory protective devices, but also how to implement them, user studies, etc. So that part that part has been missed in patient safety for many years. AHRQ played an important role. Right. I think NIOSH can do something like that, and probably also collaborating with AHRQ, because healthcare worker safety means patient safety. They are so interrelated now. So I think we need research on the science of implementing these things efficiently, consistently, and safely. Thank you.
Well, let me thank this wonderful panel for really covering a very broad swath of topics related to research priorities, education needs, communication risk during public health emergencies, and regarding respiratory protection programs. So my sincere thanks to all of you for this wonderful session.
Oh, thank you.
Melissa?
So, colleagues, we're going to take a 15-minute quick break. Please come back in quarter to the hour, and we will have a wrap-up session with the planning panel trying to pick out some of the important kernels of the conversation over the last 2 days.